Hello, everyone. My name is Jay, and I will be teaching to you the pediatric nursing. And today we will start with the disorders on the integumentary system. And so please join with us today regarding the topics that I'll be talking to you about. So we'll cover the key concepts and clinical tips to ace your exam, focusing on skin conditions in children. The first topic that I'll be talking about is about eczema. This is known as the contact dermatitis or dermatitis itself. And so this is a disorder where there is what we call a superficial inflammatory process involving primarily the epidermis, which is basically the outermost layer of the skin. And so there are different types that we should know about. So these are your atopic dermatitis. We also have the contact dermatitis and the stasis form of dermatitis. And so what's the difference between the three? Now, let's define first what an atopic dermatitis is. And so this is a condition wherein there will be the appearance of the excoriation or lesions on the both sides of the body. For example, the skin may be having lesions on both legs. However, when we are talking about contact dermatitis, this is mainly going to appear on the skin area where it touched the irritating substance. And stasis dermatitis is something that is less common in children, but in adults, it's also known as the gravitational dermatitis associated with venous insufficiency. Now, this is something that eczema is associated with history of the disorders such as allergies, could be asthma or allergic rhinitis. Now let's talk about the different forms of the dermatitis. There's what we call as infantile, there's also childhood and also pre-adolescence and adolescent form of this disorder. Now, when we are talking about infantile type of dermatitis, it begins at 2 months to 6 months, and it can decrease in incidence with aging, and it can spontaneously will have a remission after 3 years. Now, the childhood type of dermatitis, it can follow the infantile form, and this can occur at 2 to 3 years of age. Now, the pre-adolescent and adolescent type of dermatitis, this is going to occur at 12 years of age, and it may continue to early adulthood, or it can continue indefinitely. Now, most of the chief complaints or the problems that we will encounter with as pediatric patients are the following. They will be complaining of itching. And so I created here a mnemonic for you to remember that states, itching reduces satisfaction, skin making woes. Now, that stands for the itching, the redness, the scaliness, the minute papules, which are actually firm, elevated, and they're characterized as less than 1 centimeter in diameter. And also, when compared to the vesicle type, this is similar to papules, but they are becoming more kind of fluid-filled. Now, the weeping and oozing and pressing of lesions can also be assessed into this patient. Now, where do we find these lesions? Now, we can assess them in the following areas. It could be in the face, or it could be in the creases of the elbows. It could be the scalp, the knees, the neck, the wrists, and the ankles. So these are the common areas that we can definitely look at for this disorder. Now, what are we going to provide for this patient in terms of nursing care? Well, we can provide them the following, which are basically oatmeal baths and also moisturizers. These is most commonly used type of intervention because it has soothing effect, and it also has emollient type of characteristics. And so when you're applying the oatmeal baths, make sure that the water temperature is tepid. It should be in room temperature. Do not make it cold or make it warm. And the bath time should be limited to at least 5 to 10 minutes, or else it can also cause dryness, excessive dryness into the child's skin. Now, we definitely need to moisturize the skin after completing the bath, and also apply petroleum jelly for the face, and also apply with thick moisturizing cream for the body. Now, definitely we can also administer some topical medications as ordered by the medical provider. So those topical medications could be in the form of antihistamine, it could be the corticosteroids or antibiotics. So of course, when we are administering the antihistamine ointment, it has to be applied all throughout the area that is affected thinly. And also, same thing with the corticosteroids. Now, there is also a need for us to teach the parents, the pediatric patient, regarding avoiding common irritants. And so these common irritants might be present in the home setting. And this could be in the form of an irritating soap, detergents, fabric softeners, diaper wipes, and powder. So maybe these are substances that have been used widely at home. So it's very important for us to make careful assessment and interview our parents, patient's parent, to make sure we identify those irritating substances. And also, we need to teach the patient's parent to avoid any precipitated conditions. And this can be brought about by the, let's say, wet diaper, something like that, or let's say excessive bathing, or it could be heat, or maybe application of woolen clothing or blankets, or it could be exposure to furry stuffed animals and probably latex products. And so these are things that need to be identified in order to prevent recurrence. Now, also, we have to teach the parents about the use of mild detergents when they're doing the laundry, and also making sure that they are carefully doing the hand washing in order to prevent possible infection into the areas that have developed the lesions. Now, we want to make sure that our parents understand that the lesions can also develop infection. And so they need to be taught on monitoring the area, the skin, for any signs of infection. And mostly, these lesions can appear as honey-colored crust, wherein the surrounding area has some redness. And this is something that needs to be addressed right away by the medical provider. And so this is something that you need to be reminded of, especially when you are dealing with this pediatric patient. Now, let's move on into the next disorder here, which is the impetigo. This is also a common childhood skin disease wherein it has the ability to be infectious. It's very contagious, wherein through contact, a person can definitely get this type of infection. And this is caused by these microorganisms such as your GAS, or known as the group A Streptococcus, or it could be the Streptococcus pyogenes, or the Staphylococcus aureus. So remember these three common microorganisms causing the impetigo. Now, this is something that can occur in children, especially during humid, hot months, especially during summertime. And so this is something that need to also be taught to our patient's parent in order for them to be aware of what to expect during the following summer months. Now, the patient will have this distinct appearance in their face when they have the impetigo, all right? And so this kind of problem is usually associated with poor hygiene. Not a good thing to have, right? And so it can also occur as a primary infection, or it could occur as a secondary infection, maybe caused by like an insect bite, such as maybe a site that has an original rash, or maybe atopic type of dermatitis, or it could be caused from an area that had poison ivy or poison oak. And so this can be seen mostly in the patient's face. It could be the mouth, also the neck, the hands, and also the patient's extremities. And so the lesions can appear. Sometimes it can be composed of vesicles, okay? Could be pustules, wherein there is now some kind of edema and redness, which is similar to a vesicle, okay? So there's a difference between a vesicle or a pustule, wherein the pustule will have that fluid content that is becoming more purulent, okay? So that's the total difference between pustule and the vesicle. Now, the impetigo can also develop into an exudative type, and also there will be some crusting in the lesions. And so this can become serous. It can be some sort of a vesicular type. It could become cloudy as well, and it can rupture, which will leave that honey-colored type of crusting covering the ulcerated basis. So this is the characteristic look of the impetigo. Now, the other problems that you can see in this patient is we have here is the Be Prudent Best solution. That's my mnemonic for the following manifestations, such as the blisters and honey-colored crust. There's erythema, there's pruritus, there's burning, and also secondary lymph node involvement if the impetigo has not been treated for quite a long time. And so there will be some lymph node enlargement as well. Now, what are we going to do for this patient, since this is a highly contagious problem? Now, we want to make sure when they're admitted to the hospital, maybe they're not only complaining about the ulcers or the crusting, but they might also have some active infection. And so what we're going to need to do is to make sure that we are placing them in contact isolation. And also, we're going to have to include standard precaution and also other agency-related type of precaution in order for everyone to be safe in taking care of this patient. Now, we want to make sure that we are going to practice strict hygiene and also hand washing because of the highly infectious microorganism. And so what we're going to need to do here in our treatment is to include the application of the topical antibiotic ointments and to make sure that we are getting the medication, or we are properly applying the medication from the antibiotic container into the patient's wound. So we want to make sure that we are using a clean or sterile cotton swab without touching the tube, opening with the fingers and the skin. And so you got to be careful with that because we don't want to contaminate the medication container itself. And so please remember, or please take note that with impetigo, the infection is still active or is going to be communicable for 24 hours beyond the initiation of the antibiotic treatment. Please remember that. So it's highly contagious still. Now, the patient's areas where there is exfoliations or lesions, we're going to have to make sure that we are applying gauze bandages over the lesions, and also making sure that we are covering it or securing with a tape in order to prevent it from being open and exposed to air. Now, we want to make sure that we're also taking care of the patient's hygiene. For example, if they need to be helped, or maybe the parent will be assisting in administering a bath of this pediatric patient. Usually the bathing will include the application of antibacterial soap in order to lessen the infection. Also, there will be application of warm compresses, at least to be applied 2 to 3 times a day. And this is going to soften the crust and to easily remove the crusted area, and also to make sure that we're promoting healing. Now, also here, we want to make sure that we are, or let's say the parent will have to use a mild soap instead of using those astringent type of soap in order to lessen the irritation. Now, it's very important for us that we are educating the patient's parent, especially with antibiotic therapy. And it's very important for us to emphasize the importance of compliance to the antibiotic therapy, making sure that even at home, when the patient is sent home with the antibiotic, that they need to complete the entire regimen in order to prevent resistance to the infection. Now, another importance about to teach the compliance therapy is to prevent the occurrence of glomerulonephritis, which is going to be a complication, which is the result, complex that is going to affect the kidney. Okay, so this is caused by a streptococcal type of the infection, which will cause damage into the kidneys. Now, also, we want to make sure that we are also teaching the patient's parent to properly apply the emollients, to make sure that they are keeping the child's fingernails short, and also making sure that they need to practice strict hand hygiene, and also making sure that they are disinfecting the bathtub with bleach after they use the bathtub. And then also they need to make sure that there will be no sharing of the linens, even towels, utensils. Those are not to be shared at all, especially with the siblings or other family members. Another thing is to make sure that there will be separation of the dirty clothes, or let's say separating the laundry from the infected family member from the other family members. Make sure that the parents will be washing with the use of hot water and with that detergent. So these are the important things that you need to incorporate in teaching the patient's family in order that they can properly save or safely care their sibling and family member. Now let's move on into the next topic here, which is also a common problem in childhood. And this is what we call as the Pediculosis capitis, or the lice. And so this is a infestation of the hair and the scalp with lice. And so this can also affect different sites in the body. So take a look here, that it can affect the occipital area of the head. It can also infest behind the ears and the nape, the neck, and also the eyebrows and eyelashes. So please take note about how it looks like, because I haven't seen really a real pediculosis capitis in a patient. So this is what I got. You will see this white specks. So these are the nits that have been laid by the female louse. And so the problems that you will encounter with this pediatric patient is that they're going to excessively scratch the scalp, and they will end up with some lesions in their scalp. They will have pruritus, so they would probably become restless, crying at night. They will not be having restful sleep. And so some pediatric patients might end up with secondary type of infections brought about by the scratching of the scalp. Now, please take note here that we definitely need to make sure we are attending this patient when they're admitted to the hospital. And this is something that we also call for contact isolation. Okay, please remember this. This is going to call for contact isolation for this patient when they're admitted to the hospital. Make sure that you are properly putting on gown, hairnet, mask as much as possible, and wearing the shoe cover as well. Make sure that you are protecting yourself from the exposure of these infestation. And so what we're going to expect here when we are treating the patient, when they're admitted to the hospital, is that they're going to be given in order to be treated with a pediculicide treatment. And one common treatment here is the Lindane shampoo. Okay, so this is something that is commonly used. However, this is not advisable to be used, or it is contraindicated in pediatric patients of less than 2 years, because it has the potential to become neurotoxic and it can cause seizures. Please take note of that. Okay, so lindane is contraindicated in pediatric patients of less than 2 years old because it can cause neurotoxicity and seizures. Now, this is something that needs to be removed also. I mean, the nits will have to be removed daily through the use of the comb. Now, another treatment that we will be expecting to administer is the spinosad 0.9% topical solution. And so this is a much more safer, treatment for the infants with the pediculosis capitis. Now, we have to expect that there would be daily removal of the nits with a very fine comb. And of course, the person, especially the nurse that will be doing this, will be wearing gloves, of course, with the gown, protective gown. The hair brushes would need to be discarded or soaked in boiling water for 10 minutes in order to prevent colonization or, let's say, infestation of those equipment. Now, we need to make sure that we are teaching our parents, especially when they will be sent home with pediculosis treatment. We want to make sure that they are aware that there should be no sharing of grooming items such as combs, brushes, headwear, clothing, and also making sure that when they're doing the laundry, they should set the water temperature to a high temperature with the use of a detergent, and making sure that they are using hot dryer for at least 20 minutes, okay? Another thing is that the parent needs to be taught about changing the beddings and clothing daily in order to prevent the infestation of the linen, and making sure that these linens should be washed immediately and not kept in the hamper, because this can cause colonization and also infestation of those material. And making sure that they are taught to seal toys in plastic bag. For those toys that are not supposed to be washed, these are going to be placed in a plastic bag and sealed for about 2 weeks in order to allow these nits to die for that whole duration. Now, also making sure that the parents of the child will need to do the frequent vacuuming of the furniture and also with the carpets. And I'm talking about daily vacuuming, not weekly, right? So these are the things that we need to incorporate in our teaching into our patients' parents. Now, next problem that I'll be talking about will be the scabies. All right. So this is another common problem in the pediatric population, which is caused by the infestation of the Sarcoptes scabies, or known as the itch mite. And so this is a very common in school children or in the adult population as well, especially for those who are institutionalized, especially for those who have been placed in prisons, in closed quarters. These are the high-risk people to get
Stancoast NCLEX coaching.
Now, the process itself, it is going to involve incubation and infectious period. And so when we're talking about incubation period, this is the time when the female mite, it's going to burrow into the epidermis, it's going to lay eggs, and it dies in the burrow after 4 to 5 weeks. After that, the eggs will hatch in 3 to 5 days, and the larva mature, and it will complete the life cycle. However, in the infectious period, this is when the scabies can be infectious all throughout the course of the infestation. Okay, so as long as a person still has the scabies infection, they're going to be highly contagious. Now, what are the problems that we are going to be looking at into this patient? Well, they're going to be having pruritus. Look at that color of the skin. It looks angry red. And so they're going to have that pruritic papular rush. And also, they're going to be burrows into the skin. There will be fine grayish red lines that may be difficult to see. And so we definitely need to treat this kind of infection. And so we are going to expect the administration of a scabicide known as the permethrin. And this is something that's going to be prescribed by our medical provider. And this is usually cautious when you're applying this. And also keep in mind that this is to be applied 30 minutes after bathing, making sure that the pediatric skin is thoroughly dried, and it has to be applied away from the eyes because it can be toxic to the eyes. And so it is going to be left on the skin for at least 8 to 14 hours. And then the next day, they're going to have to be bathed again. And then the same cycle, we're going to have to apply the same type of ointment into the areas where the lesions are. Now, we definitely need to teach our parents when they're involved in the care, they need to be doing frequent hand washing, making sure that they change daily clothing and beddings, especially when they will be sent home with an infected child, making sure that when they are washing the linens in the washer, they have to use hot water with a detergent and make sure that they're drying it for at least 20 minutes, high temperature as well. And the linen should be ironed before use. Now, this is going to be done for at least 1 week, okay, while the treatment is ongoing. Now, another thing that we need to teach our parents will be to seal those non-washable toys in plastic bags times 4 days. Now, make sure that they are aware about what to do with the pediatric or their child's toys. Now we're going to have to shift into another important topic, which is all about burn injuries. And this is something that you probably will not encounter when you will be exposed to a medical surgical unit. Usually what you will encounter this problem when you will be in the pediatric, or let's say you work in a burn unit. And so the burn injuries, it's categorized in 3 different things, okay? So there's what we call as the thermal, there's cold burn injuries. It could be caused by chemical, it could be caused by electrical or radioactive. And so when we're talking about thermal type of category here, this is going to involve exposure to open flames, could be hot surfaces, maybe the child accidentally touched the open fire, or maybe the stove, or maybe hot liquids, or it could be anything, flat iron maybe. Now, the cold type of burn injury could be from exposure to extremely cold temperature. Maybe the child has been exposed outside for quite a long time. For a chemical type of category, this is going to be caused by, let's say, an alkali or acid, or any organic compounds that you can find in the household, especially cleaning agents such as your sodium hypochlorite or bleach, or let's say Lysol, those kind of things. Now, electrical category, this is something that can occur when the current will pass through the pediatric patient's body, and it can cause severe burns, including loss of organ function. It could cause destruction of the organ, could probably lead to amputation of the limb. It can affect the cardiac function and also the pulmonary function. They might go into cardiopulmonary arrest. Now, radioactive type of burns is something that can occur when our pediatric patients are exposed to ultraviolet light radiation or any kind of radioactive therapy when they undergo, let's say, cancer therapy, radiation type of therapy. Now, so these are the things that you will probably see or commonly see in the home setting here. Child reaching for those items that are hot, especially those cookwares, or let's say the stovetop that have been freshly used. So be aware of those things. Now, it's very important that we are also teaching our parents to make sure that they know how to prevent these things from happening. Of course, this is something that probably will be neglected, but it's very important that we know what to do. And so one thing is to make sure that they are reminded to make sure that they are providing adequate supervision to their children when they're at home. They should not be left unattended when they are playing in the living area, especially, and to make sure that they will have a safe play area away from all those wires, cords, or let's say not allowed to be alone in the kitchen area, or let's say the basement area, or let's say the garage, and making sure that we are keeping or teaching the parents to make sure to keep hot liquids or electric cords or let's say dangling objects out of the child's reach. And we want to also need to consider that when the burn injuries or when the children will sustain burn injuries, especially the very young, please consider that there is a much higher mortality rate for the severe burns in young children compared to adult clients or let's say older children because of the composition of their body. They have smaller body surface area and also the organs that are quite immature in this stage. Now, the children here has increased vulnerability to cardiovascular issues and caused about by possibly from shifting of fluids during the first 24-hour period after they sustain major burns, and also making sure that when the burn extends greater than 10% of the total body surface area, this will definitely call for fluid resuscitation during the early hours of the burn episode. And so the children are also at higher risk for caloric and also protein deficiency when they sustain burns, especially with the need for them to heal. They definitely need to have that. So we have to make sure that our care plan is well suited for this population. Also, kids will be prone to develop much more scarring. They are placed at higher risk for infection with the burns, and it can cause growth delays when they sustain major burns as well. Now, please take note that we are going to at least estimate the extent of burn injuries with the use of the following: the rule of nines, which is a very common method, and also the Lund and Browder method in assessing the burn injury. Now, please take note, guys, that the rule of nines, or is simply called as the Wallace rule of nines, this is basically an estimation of the body surface area on the assigned percentages to different areas. And this is only something that is applicable to patients, pediatric patients that have second and third degree burns. So please take note of that. This is only applicable to patients who have undergone second or third degree burns, or let's say they have sustained partial thickness and full thickness type of burn. However, this is something that is not really suited for those younger patients, for let's say pediatric patients. So this is applicable into those patients that are greater than 10 kilograms and less than 80 kilograms defined by BMI. So this is not really an ideal assessment, correct assessment of the burn, the extent of burn injury. However, we do have a different method in measuring the burn extensive
Stancoast NCLEX coaching.
burn injury here. And so we have the Lund and Browder chart. So this is something that is more complicated. This is much more of an accurate, and this is widely used in measuring or calculating the total body surface area, especially with the area of injury. And so you will see here that the areas are subdivided into the head, the neck, the anterior trunk. You have the right buttock, the left buttock, the genitalia, right upper arm, left upper arm, the right upper arm, left upper arm, the right and the left hand, right and left thigh, right leg, the right and the left foot. And so each age group here, especially for the 1-year-old, they have their own percentages of how much score or percentage that you're going to give into that particular area of injury. And so this can vary according to the age group. If the pediatric patients is somewhere between 1 year to 4 years old, they're going to have a different percentage. For those pediatric patients that ranges from 5 to 9 years old, or 10 to 14 years old, or 15 years old. And so this is something that is not very easy to really use because it will involve accurate calculation. It might slow down the assessment process during the acute phase. And so this can be cumbersome for those new medical practitioners or those new nurses that are not have used the Lund router method yet. And so it's not very advisable for those medical practitioners that are not familiar with this to not use this kind of method. And so some of them will be allowed to use the rule of nines. However, if we are going to be asked about the accuracy of the percentages in the burn injury, then we're definitely going to use the Lund router method. Now let's talk about the severity of the burns according to the depth. So here we are going to compare the following degrees, first to second, third, and also the fourth degree type of burns. And so you will have here the layer of the skin from epidermis to dermis to the subcutaneous layer to the muscle and to the bone tissue, which I do really not include. But here we have the row at least. And so when we're talking about the depth of the burn according to the severity according to the depth, well, of course, when we are assessing a patient with a first degree burn, it's only affecting the epidermis. Please take note of that. And this is something that is going to be called as superficial partial thickness. So whatever you see in a person that might have been overexposed under the sun, let's say sunburn, then that is considered as the first degree burn, superficial partial thickness type of burn. And this is something that you will see as that the skin is intact, there will be no blisters, the skin will have the classic pink or red appearance. However, when you're going to apply pressure on the area that is burned, you're going to see some blanching, okay? And so it blanches with pressure. So please take note of that. Now, this type of burn can actually be relieved a little bit by the application of, let's say, a fan, cooling. You might see some slight edema into the area that has been slightly burned. However, we're going to have to talk about the kind of sensation. It can become painful. For you, though, for those of you who have encountered or have experienced in first degree burn, it is very painful. And the course of healing can vary. The discomfort can last from 48 hours to 72 hours. And also, you will see that this type of burn will be followed by scaling, or let's say desquamation, in about 3 to 7 days post-exposure to the sun, okay? Or let's say to the agent that has caused the first degree burn. Now let's talk about the second degree burn. This is going to affect both the epidermis and the dermis. So this is what we call as the deep partial thickness, wherein this is now going to involve the destruction of the epidermis and the upper layer of the dermis. Or it can also extend into the deeper portion of the dermis. Now, when we are assessing, this can look as wet, it can be shiny, it can weep. So there will be a little bit of drainage here. There will be formation of blisters. There will be blanching when you're applying pressure into the area of involvement. So please take note of that. There will also be blanching. Here, the site is also painful. And here, it's going to be sensitive to touch, or it can be sensitive to air currents, such as a fan. So we definitely need to not to apply or expose them to a fan. Now, what we're going to expect here is that the healing can last less than 21 days. for the superficial partial thickness. However, the healing will be longer than 21 days when there is deep partial thickness type of burn. So please take note of the differences here, all right, between superficial partial thickness and the deep partial thickness type of burn. Now, for the third degree burn, here it's going to affect both the epidermis and the dermis. It can also include the injury to the fascia, to the tendon, to the muscle, subcutaneous fat. And so here we are going to consider that this is what we call this full thickness, deep full thickness. So it is expected that there is now total destruction of both the dermis and the epidermis. So I want you to think about this. When the patient will sustain third degree burns, there is no more regeneration of the skin because there is now removal, entire disappearance of both the epidermis and the dermis. So there is no more skin regeneration. Now, the patient here will have a characteristic, or there will be a variability in the color of the burn. It could be brownish or black area of burn. The surface will become dry. There will be some appearance of thrombosed blood vessels. There will be no blanching here because there's no more epidermis and dermis. Now, since in this degree of burns, it is affecting the layer where the nerve endings are, and so you will expect that this is going to be insensible. And there is a decreased pinprick sensation, all right? So please expect that. However, when you are expecting for the healing, it can involve the use of an autograft. So surgical procedure, transplant of skin grafts. Now, we are going to talk about the fourth degree burns, which is going to be involve the epidermis, dermis, the fascia, tendons, muscle, and also to the bone. And so here we are going to expect that there will be the variability in the color. There will be eschar formation, brown, like fried, deep characteristics. There will be charring, visible charring of the affected area. And here, the person will have limited movement of the limb, okay? Extremities, or it could be the leg or the arm. These areas are going to be very, maybe the areas now has extensive injury. There will be no more movement that you expect in a normal person. And now here, there is no more sensation to be expected, and that this degree of burn is something that will require autografting, and also it can require amputation for those areas that are no longer be salvaged, okay? And so the healing process here can definitely take a while, from weeks to months, even for some patients that may encounter infections, because they are really prone to developing infections when the areas, those areas underneath the skin are exposed to the outside environment. They're very prone to develop secondary infections. And so you got to be careful in assisting these type of patients. Then we're going to talk about the different classification, and we're going to classify it according to minor, or it could be moderate or major. So what does these three classification mean? And so a minor type of burn is something that is considered as a first and second degree burns that cover only less than 10% of the total body surface area. Please take note of that. A minor burn is considered when there's only first and second degree burns that is less than 10% of the total body surface area. And here, it is not expected that the patient will be admitted to the hospital.
Coaching.
Maybe they're going to be seen at the outpatient clinic and will be sent home with treatment. However, when we are going to encounter a patient that may be termed as moderate type of burn injury, this is now going to involve with a second degree type of burn that cover about 10% of the total body surface area or greater. However, when we are going to encounter a patient with a major type of burn, this is now going to involve those people that have third-degree burns that cover more than 1% of the total body surface area. Please take note, 1% of the TBSA, however, they have third-degree burns. Please take note of the percentages. Now, please take note here, guys, that there are so many things that we need to expect as complications from the exposure to the agent that caused the burn injury. One is arrhythmia. So this is something that you can find in a patient that might have been electrocuted, or let's say dehydration for those patients that might have extensive fluid loss because of the fluid shifting. They're going to end up being dehydrated as well. Another is edema. This is going to the accumulation of fluid in the burn area. So this is going to cause impairment of the circulation to the affected limb. It might cause compartment syndrome, and it might cause tissue damage to the area. Another complication that you might encounter to this patient is sepsis because of the increased vulnerability to infectious microorganism. And so there is much more higher, or there's a higher risk for the infecting microorganism to go into the bloodstream, which can become a life-threatening condition. Now, another problem or complication that you will encounter is with hypotension and also shock. It is because of the vital, or let's say the shifting, the major shifts of the fluid from the interstitial, or let's say the cellular compartment, and also it could be that the patient might have sustained a major area of burn injury. Okay, maybe a large area of muscle area has been burned, so they're going to develop hypotension and shock. Post-burn, another is pneumonia. It's because of possible inhalation of the hot gases, or let's say smoke during the fire, which can damage the lung. It can cause pneumonia, and which will also impair the lung function. Another is organ failure, and this is something that is associated with the stress on the body, especially when there is low blood pressure, there is shock. The blood supply to the major organs in the body will be greatly affected. And so multi-organ failure is something that you will expect in these patients. You know, contractures is very common, especially for those patients that might have been injured by third or fourth degree burns. It will cause the skin to tighten, or let's say the layers of the body tissues will begin to tighten. It will restrict the movement, and it can lead to contractures and will impair the function, and subsequently will cause disfigurement in the pediatric patient. Now, what are we going to do here? So for the minor burns, we are going to stop the burning process. We are going to put the patient away. So if we are out there, let's say in a situation where we are the responder, so we want to make sure that we are stopping the burning process. We're going to place the patient in a horizontal position and roll him in a blanket to extinguish the fire. And then we are going to remove the clothing and or maybe jewelry that may conduct the heat. And we're going to apply tepid water soaks or run water over the injury instead of using cold water. So we definitely need to make sure that we are going to cover the burn area with a clean cloth. And by the time when they arrive in the ED, the area will be replaced with sterile gauze bags. Now, with the care of the minor burns, it's also gonna call for the use of mild soap and tepid water, okay, and to decrease the irritation of the injury. Now, we're going to administer antimicrobial ointment to the site, also making sure that we're applying appropriate dressing. They should be non-adherent, they should be colloid in order to decrease injury, and make sure that we are providing warmth to our patient. We don't want them to become hypothermic at this point. And also the pediatric patient need to be attended right away with this type of problem. Okay. Now, the administration of pain medication is very important in order for us to properly treat the patient. So it could be in the form of a non-steroidal anti-inflammatory agent, or it could be in the form of a Tylenol or acetaminophen. We want to make sure that we are carefully assessing the pediatric patient. Now, it is very important that we are also checking the immunization status of our patient, and also make sure that we are administering tetanus vaccine as ordered, especially when they're exposed in the environment where the infecting microorganism is. And also make sure that we are teaching our parents to avoid the use of greasy lotions, or let's say the use of butter and burns, because these are things that are for sure going to be used in the home setting. And so we are going to teach them to avoid these substances, because these are going to trap heat under the burn area. So this is a big no-no. We want to make sure that we are also teaching our patients to monitor the burn injury for any signs and symptoms of infection. Now, also here, we want to make sure that we are treating properly our patient, especially when they have major type of burn. So we are talking about third, fourth degree type of burns, or let's say greater than 1% of total body surface area. We want to make sure that we are maintaining their airway and also ventilation. So this is very quick when we find our patient, or let's say if they arrive from the scene, especially if you work in the emergency department, we want to make sure that the airway is open, maintained open, or also the patient will have patent airway. You don't hear any rhonchi, because, or a stridor maybe could be a sign that there is now narrowing of the airway, okay, due to the exposure to smoke. Now, we definitely need to apply humidified 100% oxygen as ordered to this patient. That will require administration of oxygen, because they are prone to develop hypoxemia at this point. It could be in the form of a nasal cannula, or it could be through the use of simple mask, or however the doctor wants us to treat this patient. And so definitely we need to make sure that we are monitoring our patient's vital signs carefully, and to look for those very subtle changes in the blood pressure, heart rate, fluctuations, temperature, and also oxygenation status. We want to make sure that the team is aware of what is going on with our patient. Now, we definitely need to make sure that our patient is able to maintain cardiac output, because when they have extensive burn injury, especially third or fourth degree burns, remember about the shifting of the body fluids. They all run out of the circulating blood volume. There will be fluid loss. And so there will be compromise in the oxygenation of the major body organs when there is fluid loss or blood loss caused by the burn injury. Now, also, we are going to make sure that we are prepared to insert large bore IV access, gauge 18 IV. And this is going to be used for rapid IV bolus during the acute phase. Make sure that we are going to replace the IV or provide IV replacement to this patient, especially with a major or extensive burn injury. Now, I'm not kidding, but this is something that you need to keep an eye on. Make sure that we are assessing carefully the patient's extent of the burn using the rule of 9 or the Lund-Browder method, making sure that we have captured the correct percentages of the burn injury in order for us to properly treat the patient with the IV fluids, because we don't want to overdo the fluid administration as well. Now, we got to make sure that we are treating our patient and also monitoring them for any signs of shock. So these are things that you need to keep an eye on. It could be a drop in the blood pressure, tachycardia, the respiratory rate will be higher, and also the saturation of the patient will kind of fluctuate, will have to trend down. And so these are things that need to be assessed carefully. Now, another thing that we need to provide to this patient is to manage carefully the patient's pain. Now, what are we going to do here? Especially, we're going to have to administer maybe in a form of IV morphine, or it could be hydromorphone. Also, making sure that we are evaluating their pain level from time to time, okay? Making sure that they are receiving adequate pain control. Now, let's go back into the treatment, IV fluid replacement. So this is something that you need to keep an eye, because in the first 24 hours, usually the patient will be receiving crystalloid solutions, and these are your isotonic solutions. Could be the lactate bringer solution, and this is very important. These are going to be administered as bolus, okay? Now, after the 24-hour period, supposedly they're going to receive, maybe if there's a need, they're going to be transitioned into the colloid solutions like your albumin, or it could be plasma. And this is going to be administered 24 to 48 hours post-burn injury. Now, please keep in mind that when you are treating our patient with the IV fluids, or let's say the colloids or the crystalloids, we want to make sure that we are monitoring the patient's urinary output hourly, okay? So please be reminded about the adequacy of the urinary output. So in order for us to know,
Stand
we want
Coast
to make
NCLEX
sure that
coaching.
at least the pediatric patient will have 0.5 to 1 ml of urine per kilogram per hour, okay? So this is something that you need to keep in mind of. Make sure that you are checking the urine output hourly. Make sure that they achieve at least 0.5 to 1 ml per kilo per hour, okay? And this is something that you should do if the child weighs less than 30 kilograms, or let's say less than 66 kilograms. Now, if the patient weighs more than 30 kilograms, or let's say more than 66 pounds, you want to make sure that the minimum urinary output is at least 30 mLs per hour, okay? Again, 30 mLs per hour will be your criteria or criterion for a child that weighs more than 30 kilograms or more than 66 pounds. Now, why are we measuring the urinary output hourly for the burn patient? Well, as we have known that the cardiac output will be affected because of the fluid shifting, fluid loss, we know that the kidneys receive 20% of the total cardiac output, supposedly. So if there is a significant disruption, there is significant reduction in the circulating fluid volume, it can compromise the blood supply and also perfusion to the kidneys. So our patient can probably develop renal failure post-burn, okay? So that is why we really need to make sure we are monitoring the patient's urinary output during this critical phase. Now let's move on into the nursing care as far as preventing infection. Well, we want to make sure that for those healthcare providers that will be involved in the care of the patient, make sure that they are going to gown up, make sure that they're going to have to use the proper PPE. Our patient will be placed in a protective type of isolation because they're prone to develop opportunistic type of infection. So this is something that you should be doing to our patient. Now, another thing is to make sure that we are monitoring our patients for any signs of shock. I'm talking about septic shock, because our patients are prone to develop these opportunistic infection. The patient usually will start with an alteration of their sensorium, their level of consciousness. They will become disoriented, confused. Our patient's capillary refill will be increased. I'm talking about greater than 3 seconds, which is not a good thing. So make sure that you are thinking about the sensorium, the level of consciousness of the patient. The cap refill should be not more than 2 seconds, making sure that you are monitoring the patient's body temperature. A spike in the body temperature is not a good sign. also take a look into the color of the skin. If there is now mottling, there will be like purplish, bluish discoloration of the lower extremities. Or let's say when you're touching the patient's legs and they feel cool to touch, that's not a good sign. And so make sure that we are monitoring this and report immediately to the physician, especially. Another thing is that our pediatric patient will end up with decreased bowel sounds. If that is a sign of septic shock, the heart rate will be rapid. It could be greater than 160, 150 beats per minute, according to the range, because our pediatric patient really has a variability in the normal ranges, right? And so anything above the normal upper limit is considered as already tachycardia for abnormal heart rhythm, or let's say, and also for the breathing, if they are rapidly breathing, tachypnea or dyspnea, those are things that need to be attended. Another is the reduction in the urinary output. So if your patient's urinary output through the use of a Foley catheter urinary bag, if you're not really getting enough urine output per hour, you definitely need to report this to the physician. Now, another important care that we need to be providing to our patient is through the administration of nutritional support. And so it can be in a form of, let's say, nasogastric tube feeding, or if there is what we call as paralytic ileus, which is a complication of the burn injury. They probably would need the use of the central line. Our patient will be given the total parenteral nutrition, or TPN as word. So please keep in mind of that. Now, another nursing action that we have to provide to our patient is to make sure that they're going to restore mobility, and this is going to be a lengthy process, okay? And so this can take months, especially if there is a huge involvement or a massive area of involvement in the burn site. Now, we want to make sure that we're also providing psychological support, especially to the pediatric patient, the parents in themselves. We want to make sure that they have the proper support in order to allow them to have much better coping strategies during this difficult time. So this is something that you can also provide to our patients. Now, let's go back a little bit into the restoration of mobility. So during the acute phase of the burn injury, we want to make sure that we are placing our patient in the correct body alignment and properly apply splint the extremities and properly put them in a position that could not help or that could prevent the formation of the contracture. So these are things that you want to make sure is provided to our patient. We want to make sure that we also maintain active and passive range of motion exercises, and also, if allowed, we have to assist the patient with ambulation as soon as they're able to do it. Other than being, if the physical therapy is involved, the multidisciplinary team will be involved, especially during the rehabilitation phase. Now, in some cases there is a need for us to apply pressure dressings. There might be need for us to do that in order to prevent contractures and formation of scarring. We also need to make sure that we are monitoring those areas of high risk for skin injuries, such as your heels, the sacrum, the back of the head. So these are areas that need to be checked at every now and then during your shift. Now, here we have the pharmacological agents that will be given as part of the treatment. Now, what are these things that you will be seeing? Now, part of that will be the application of the silvadin sulfadiazine. So this is a very common treatment that has an antimicrobial property. So this is something that is going to be used for those patients that have second and third degree burns. And so this is only applied to the area that has already been cleansed, that has already been debrided, okay? And so when you are applying this medication to the site, make sure that you are wearing sterile gloves when you're applying the ointment, and make sure that you are applying a fine mesh gauze. However, please take note here that the silver sulfadiazine has adverse effects such as the oculotoxicity. And so make sure that you should be careful in applying this, not to be applied near the eyes, because it can cause visual problems. And it can also cause pseudoeschar formation, which is going to complicate the healing process. And so you will see this as loose wound edges. And so it is very important for us to monitor this to find out what this is, pseudoeschar formation. And there is that characteristic loose wound edges, which will require debridement. And once this is done, we've got to make sure that the area will be monitored for healing. Now, another is that the medication itself can cause impeding reepithelialization. So it simply means that when there is now regrowth of the area, okay, for those cells to regrow, whenever you're going to see those reepithelialization, make sure that the doctor is aware of this, because the medication needs to be stopped right away, because it has that effect. It can impede reepithelialization and can also affect the wound healing process. Now, the other medications that you will expect to apply into this patient with a second, third degree burn will be the methanide acetate. So this is going to be applied to a already cleansed area that has already been debrided. Same thing that you're going to do, make sure that you are wearing sterile gloves for the application of the ointment. Now, another is vasodilation. This is something that will be used to prevent secondary type of infection. And also, the patient will be receiving morphine sulfate. This is mostly the commonly used type of medication in the treatment of acute pain, especially for those patients with burns. For the second degree burns, it's very painful, guys. And so I had injured about 10% of my leg. I had injured about that 10% second degree burn. So I had blisters over the upper leg and also the thigh area. So it's very difficult to manage as far as the pain. Now, when we are administering the morphine sulfate, we want to make sure that we are properly assessing the pain level of our patient, and also counting the respirations before we give the medication, because it's known to depress the respiratory function, the central nervous system also. And so we want to make sure that our patient is safe to receive this. If in case our patient is going to be given morphine sulfate in IV route, again, make sure we are keeping an eye for respiratory depression. Make sure that their respiratory rate doesn't go down lower than 12 cycles per minute. However, for those pediatric patients, make sure that their respiratory rate is not below the normal lower limit according to their age. Now, here, another would be the application or the administration of midazolam, fentanyl, propofol, nitrous oxide, which are given when our patient will be getting debridement, let's say surgical procedure to remove those debris. And this will require the eye of the anesthesiologist as well in the procedure room or the operating room. Now, with a patient with a wound, we definitely need to provide them with proper wound care. Before we do the wound care, definitely need give them some pre-medication as ordered. Please do that, because wound care can become painful. Just before the procedure, make sure that we are administering the prescribed medication, let's say IV or oral medication. If there is a need for them to be sedated during the entire procedure, please make sure to do that. Please monitor the pain level as well. And so when we're talking about pre-medication, this might involve with the use of the analgesics, hydroxyzine or the diphenhydramine, They will have some itchy sensation during this procedure, possibly. So these are important to be. You've got to pay attention to what medications the doctor has ordered for this patient. Now, we want to make sure that when we are doing the wound care, we definitely need to remove the previous dressing in order to allow proper healing, and make sure that when you do that, you have to properly assess the odors, the drainage, and also the color of the discharge. Look for the consistency and the characteristics of the drainage. Now, we definitely need to cleanse the wound as prescribed. It can vary. It can be as every 3 times a day or twice a day, or maybe much more frequent. And so you got to have to coordinate with the wound care nurse or the doctor according to what the need is. Now, if you're going to be involved with the wound care, let's say debridement, you're going to have to make sure you have to promote comfort for the patient. And I have to keep an eye if the patient might need some extra pain medication during the entire procedure as well. Now, we got to make sure that we are able to take care of our patient if possible, if they develop to the following complications. And these are the things that you need to take a look at. It could be in the form of an inhalation injury. It could be caused by the direct thermal injury. It could be through carbon monoxide injury. It could cause maybe shock or systemic sepsis, maybe because they have been exposed to the outside environment already. And so when we have our patient with an inhalation injury, we want to make sure that we are maintaining proper airway, make sure that they're able to ventilate themselves, assess for any abnormal signs such as stridor. Stridor is a big sign that there is narrowing of the main airways. And so we got to make sure that we are checking for the patient's oxygen saturation, and as needed and as prescribed, make sure that we are administering 100% of oxygen or titrate the oxygen concentration as ordered. Now, for those patients that may have the shock or systemic sepsis, usually in this period, the first 24-hour periods, like I've said, the patient will be receiving crystalloid IV fluids, such as your lactated drinkers, or let's say normal saline solution, or let's say with the use of the plasma light, and so or albumin in order to promote proper circulation of fluids in the vascular compartment. We definitely need to provide the colloid solutions and make sure that when we are addressing this problem, we are monitoring the patient's intake and output. Keep an eye for any signs of anemia, infection, because when we're treating the patient with boluses of IV fluids, there will be massive dilution. And so expect that the hemoglobin will drop because of the hemodilution. And make sure that you're also monitoring the patient's white blood cell count on a daily basis. Keep an eye on their vital signs for any type of fluctuations, their level of consciousness, sensorium, and the capillary refill. As I said, not greater than 2 seconds for the cap refill. Anything beyond that, that is going to be questionable. Now, for those patients that may have developed pulmonary problems, such as edema of the airway because of the exposure to the smoke irritants, or it could be bacterial pneumonia, or it could be the aspiration. Now, we definitely need to make sure that we are going to maintain airway, or possibly prepare the patient for intubation, or it could be prepare the patient for a tracheostomy. There is now a constriction, or let's say narrowing of the major airways, and we have to administer oxygen as prescribed. So here, definitely need to monitor the patient's oxygen status as well. Now, here for the wound infections, we are going to assess the following: the discoloration of the wound, let's say the edema, the odor, drainage. So on a daily basis, we want to make sure that we are looking into the previous assessment findings and to compare with the recent assessment findings to make sure that we're able to report these abnormal signs and symptoms. Now, we want to make sure that we're also checking the patient's temperature, especially heart rate, because these are subtle indicators for any kind of wound infections. Again, wound culture is very important. If you're suspecting that there is now onset of infection, definitely have to obtain wound culture as ordered before initiating any type of antibiotic therapy. This is the rule of thumb. Before the initiation of antibiotic therapy, either oral or IV, we want to make sure that we have obtained the wound culture or blood culture before starting with the antibiotic therapy. Another would be the administration of antibiotics as ordered. It could last for maybe 7 days or maybe shorter than that. It depends on the results of the blood culture or the wound culture as well. So there might be a need for the physician to change the name of the antibiotic or the classification of the antibiotic during the when the results of the wound culture comes back, or let's say the results of the blood culture comes back. And here we definitely need to make sure that we are monitoring the patient's laboratory results, complete blood count, white blood cell count, hemoglobin, check for any results in the blood culture or wound culture results. Now, we want to make sure that when we are doing the dressing changes, you have to do surgical aseptic technique when doing this procedure, because as we know, our patient is very vulnerable in getting opportunistic infection. Now, we are going to summarize our topics here, or topic as far as the burn injury. We want to make sure that our patient will be assessed thoroughly with the use of the Von and Browner method or the rule of nines. We want to make sure that we have thoroughly assessed the areas before we decide on proceeding with the IVF replacement, because we're IV fluid replacement, because that is very dependent on the percentage of the burn area. Now, another is the pain management. Please recall about the different modalities. It could be with the use of oral or the IV analgesics. Make sure that we are properly assessing and evaluating our patient before the administration and after the administration of the medication. Another is fluid resuscitation. Definitely keep in mind of the other aspects that you have to recall, especially the kidney function. Proper calculation of the extent of the burn injury is dependent in the fluid resuscitation. And so we want to make sure that we are not neglecting monitoring the patient's intake and output. We are making sure that our patient's urinary output is adequate to prevent any complications such as acute renal injury. Now, another is wound care, which is very important, especially when we are administering dressing changes. We want to make sure that we are very careful in addressing this. Use aseptic or surgical technique during the dressing changes, and also during when we are treating our patient. We want to make sure that we are adequately promoting nutrition, making sure that they have the right amount of caloric and protein intake in order to cope with the demands of the body's processes or metabolic processes. And we want to make sure that we are also promoting mobility and positioning to prevent contractures, education to the patient and the parents themselves, and the prevention of any types of burn from occurring. And so that's all about the burn injury. Thank you so much as we conclude this NCLEX review on pediatric integumentary disorders. And so it is very important for us to recognize the distinct and different presentations, different management approaches. And so make yourself armed with the knowledge, and also make sure that you're able to provide comprehensive care in promoting healing and enhancing the well-being of our pediatric patient. And stay tuned for more valuable insights and exam preparation resources to further strengthen your nursing skills and succeeding your NCLEX RN journey. Thank you so much for your time. Have a good day. Bye-bye.
Before we move on to the next question, we have urgent news for you. We've meticulously crafted a 100-hour animated NCLEX review crash course.